all the evidence has been summarized, or the evidence available has been summarized by ILCOR, so we don't need to summarize that again in our guideline. We refer to the ILCOR posters and updates and publications wherever it's relevant. So that might be like a different perspective of looking at the development of the guideline, I guess.
Absolutely. Let's go to the algorithms comparison and we'll see how it looks like. Okay, here we go.
Well, you can see the differences, can't you? I'm looking at the audience. The colors are different. The layout is different. Maybe the contents are a bit different anyway, but not that much. And I think there's a world of things to say about the development and the layout and the creation of an algorithm. And I'm not sure about you or Henry or John, but I'm not an expert in algorithm development, visual things, how to make it as clear as possible. So we did our best. Probably if we would have asked a professional organization or someone with training or, who does this as a profession, both our algorithms could have been even better in the future. So maybe that's something we can do together. I think when you look at the algorithm, the major differences might be that ours is more linear, if you look at it. If it's just at a first glance, that we have a box putting emphasis on what is the altered approach in a preterm below 32 weeks specifically. And that we have the longitudinal lines, like is more help needed and maintain normal temperature. But I think, so those are, I think, important differences. Maybe you want to comment on yours?
If you go into the new modification, first of all, we try to align our algorithms with the NRP so people can see perfectly fine the difference between instead of looking at difference, we are trying to align and have the same algorithm at the guidelines and the NRP textbook. And some news here is that we add the 2 minutes for the starting oxygen saturation evaluation, and also we are moving up the AKG.
Do we need to move? Okay, thank you. You move up the slides, then we continue to cord management. Henry, do you want to start on cord management?
Yeah, so the cord management, we updated the guideline on the most recent evidence reviews. And what I want to highlight first, perhaps, is that in the algorithm, which we didn't have before, we have this box initiate cord management plan, which of course means there needs to be a plan beforehand to initiate it. So it implies that you've thought about it and talked about it with the team. And I won't read all of this, but ultimately what we've talked about already, for both term and preterm infants, that the recommendation is for 60 seconds or more deferred cord clamping. We do, this is one example though, the number 2 for term, you could see, we have a gestational age cutoff of 35 weeks for the recommendation for non-rigorous term infants to consider, it may be reasonable, we say, to provide cord milking. And that was because there was one large multi-center trial that enrolled patients 35 weeks and more. So that 35 weeks, I don't think we have that gestational age cutoff for any other recommendation, but it does apply to this one. And then for preterm infants, as before, we recommend against cord milking for less than 28 weeks due to the concern for potential intraventricular hemorrhage.
John?
Thanks. So we're sort of saying the same thing. So, we're all coming from the same route, which is ILCOR. And sure, there's a few nuances or changes in emphasis maybe, but actually when you read it, it's the same. It's just we've written it differently. So we have a box, and I put a little red ring around it, and it mentions delayed cord clamping. So I guess from our point of view, it's a cord management plan. We prioritize the deferred element of cord management as the priority and try and emphasize that that's actually biologically the more superior method within the algorithm for us. Obviously, there are a few exclusions which are actually in the text, and ours is a more narrative guideline. So we have a guideline that you can read that's almost like instructions rather than a box with the evidence. So when it comes to, I guess, scientific method, maybe ours is a little less rigorous than yours in the presentation, but the spirit is the same. And when you actually read it, we're sort of saying the same things as I suspect everybody else is. So we prioritize a delay in cord clamping. There's a rather unscientific, if the baby needs resuscitation, then perhaps you should clamp earlier and maybe under 30 seconds. That was consensus rather than evidence. The idea being not to delay, but otherwise leave the cord alone and ideally to first breath or as long as you can in the babies that are fit enough to do it, providing you can maintain temperature and do everything else that you're meant to do for the baby. So there is a hint to intact cord management and resuscitation on the perineum with thermal care and so on within, and that's covered in the evidence section, which is a separate section underneath the actual practical guidelines, which isn't on the slide. Cord milking, we perceive that to be okay. It's sort of in the middle ground. It's not as good as delayed cord clamping, but it's probably better than clamping immediately. So if you can do intact cord milking when you can't do delayed cord clamping, then have a go. But it's not prioritized as the main method of managing the cord. And again, there's this 28-week cutoff, which is a generally agreed portion. So that's mentioned within the guideline as well. And that's it basically, isn't it? So we sort of say the same things.
You want to comment further on that, Henry? Here you have this an overview of the similarities and differences.
Time, yeah. So I think the next thing is airway. We were going to talk about. We're going to break for a Q&A and then.
If you want to comment on.
Oh, I see. And then okay. Is that right? But is the Q&A the rest of the time?
Yes.
Yes. No. No. Mm-mm. Is that right?
I'm letting you know that your session is almost you have a halfway.
Oh, okay. That's fine.
Yes. So,
But it's
there's no
we are being recorded.
other questions.
We are recorded. Yes.
So this is the room. So you can
Okay. Yeah, we could break for Q&A now, and then we'll continue with some of the other. Yeah. Sounds good.
Thanks. Both of them, as you said, very close to each other. Just for and forget my English here. If you go to the algorithm of the American Academy of Pediatrics, it looks like initiate cord. Yeah. Initiate cord management plan. For me, it looks like okay, you have to work on planning, not take an action. That's my English understanding, which should have been done before birth, not after birth. After birth should be implement the cord management plan. This is yeah. So that's okay. So that's for probably the non-English speakers. They may understand that at that time they need to discuss and the planning of the cord management. So
I think it's a good point. I think that you're making, Wally, but perhaps if it said initiate cord management planning, then maybe it would be like, oh, start planning then. But here we are saying something more like what you're saying is implement. But I think here initiate for us means the same thing. Of course, also due to like our goal to try to not have too many words in the algorithm, to have it as a guide that can be as sort of succinct as possible, we didn't put, perhaps on a higher box plan cord management. But in the NRP, in the textbook and the educational program, we do have as part of the 4 questions that you ask at the start, before delivery. One of the questions is, what is the cord management plan? And so I think that in the context of the whole educational program, this perhaps would make more sense as well.
So I think this illustrates one of the spiritual differences between the way we construct the guidelines, because yours is very much about the evidence, whereas ours is somewhat more practically orientated and reflects that relationship with the NLS course. So when you read what we've put on our slide, it's a set of statements around what people should do. So discuss the options for managing cord clamping with parents before birth. Perform thermal management, tactile stimulation during, and then a little bit about the cord clamping, and so on and so forth. So this is our practical approach to how we felt we would want to write our guideline.
Just one question before this. Also in the context of the translation from evidence to education, how do you manage to have all these cutoffs, different cutoffs, and teach the different providers? Because, for instance, in Brazil, it's a different cutoff, but we took the same approach to try to simplify, because we have a wide audience and we have difficulties with the different type of providers that will have to teach. So we decided to make a similar approach to the European. So my curiosity is, how do you teach these different cutoffs in the different things that you are?
So I'll just stress on the educational program. No, I'm just not speaking loud enough. From the educational program, functionally, it's actually very much the same. There are only 2 gestational age cutoffs functionally. 32 weeks nearly throughout the entire program is the only gestational age cutoff in NRP. There is one item that has a 35-week cutoff. Otherwise, everything is 32 weeks. And again, the only exception to that, I guess, would also be cord milking. We don't recommend less than 28. So it is not a variety of multiple cutoffs. There are essentially 2, but almost everything in NRP also cuts off at 32 weeks.
That's right. I think now that I think about the 35 weeks also is in our oxygen recommendation, the other cutoff. But I think ultimately it's not so different. I think even in constructing the guidelines, we were mindful of practicality and education.
So we've been instructed to move on. So we go to airway. And John, do you want to start? Well, yes, please.
So, airway. First priority after thermal care. And again, when you look at what we say open the airway. That's our algorithm. And the subtleties around that are taught on the course. And there's no specific order to actions other than an emphasis on airway positioning to begin with. And along with air positioning, we integrate that with an acknowledgement that the jaw and the tongue are part of the airway which cause problems. So we emphasize jaw lift along with the neutral position as integral parts of the initial airway opening maneuvers. And then following whatever breathing maneuver, which is another discussion, we have a number of maneuvers that we suggest are undertaken, and they're not different, I suspect, to the ones that are promoted by those in the AHA. So we have two-person airway support as an evidence-based intervention that we encourage, and we encourage that to be used early if there are two people and it's practically possible to do so. So if you're on your own, it's a single person approach to begin with. If there's two people and they're able to support each other without compromising care, then it's a two-person approach. And if that doesn't work, then there's a menu of other options to choose. And they're not in a particular order. And the idea is you apply some clinical assessment as to the probability of what you do next. So there are manoeuvres, and they would include inspection under direct vision and suction. If you feel that obstruction is a possibility, they would include the insertion of an adjunct, and the adjunct that we favour is the laryngeal mask or subglottic airway device. And it would include other things such as putting the pressure up, which is not an airway manoeuvre per se, but is nevertheless a manoeuvre which would then improve airway breathing management. Video laryngoscopes, if you're going to move through to intubation, are recommended based on the ILCOR evidence. Nasopharyngeal OPAs are included within the portfolio of devices, but not necessarily prioritized as a prime device. And that's about it, really.
From our perspective, again, it's probably not too different, but we do, I think, this time have de-emphasized suction. In fact, I believe from the algorithm, we don't have that word in there. We say clear airway. In the guidelines that we do talk about, in many cases, suction not being beneficial, but when there is evidence or suspicion of obstruction, that may be an indication for suction. We do similarly prefer TPs, especially for preterm infants, and there's ILCOR didn't review ventilation corrective steps, but that's been a part of what we've taught for quite a while. But we did review the evidence as best as we could on that to sort of build sort of evidence base for some of the things that we do in terms of the ventilation corrective steps. And similarly, we have recommended, when resources allow, to consider video laryngoscopy as when endotracheal intubation is being considered.
And I guess every recommendation that you and I make in the guidelines is depending on the clinical skills and resources of that specific person, that specific setting. Anyway, so that's very important to always keep in mind, that not everything that might be done can be done in every setting around the world. Yeah. The next discussion topic. You can start.
Oh, this is we'll go to ventilation. Okay, so you go ahead. It's me? Oh, it's me. Okay, me again. Okay. As we've discussed, ventilation is the centerpiece of neonatal resuscitation and remains so. And we have changed some of our guidelines based on a review of data, which are ultimately observational. But we have now recommended PIP of 20 to 30 for preterm and term infants. And within the recommendation, the text, there's a little bit more of a nuance discussion of, for preterm infants, considering a lower range of initial PIP of 20 to 25, the peak inflation pressure, and then for term infants, initial peak inflation pressure 25 to 30. But really, this evidence isn't, I think, so strong to say those are sort of the exact ranges based on gestational age. So our main recommendation is for a range of 20 to 30.
I will.
Yeah, so this is the irony that the most important pedestal of newborn resuscitation, which is airway breathing, is the one with the least evidence and recommendations to guide what we do, which we have talked about at length, and we'll continue to do so. So it is what it is. If we're drawing a comparison with Henry's sort of recommendations, we fixed on 30 centimeters for term as the starting pressure. I guess we came from a different direction when we were thinking about this right back in the days when we were trying to work out what to do, and we sort of approached it from a physiological point of view and tried to find some evidence, and there isn't a lot. But anyway, we've been at 30 centimeters for a number of years now, and on the grounds that you don't change unless you've got clear evidence for change, we've stayed at 30 centimeters for term. In 2021, we moved from 20 to 25 for preterm on the basis of a review of the evidence that suggested actually you might need 30 for preterm as well, but we didn't have the nerve to go to 30, to be honest, so we went to 25. And again, on the grounds that there's no evidence to move that, we've kept it at 25. So we're 25 for the preterm, and we're at that 32 gestation age because that's our universal intervention line. And the algorithm supports that in its graphic because there's a little box to the left-hand side of the main core, which has the preterm recommendations, and it says 25.
Nothing to worry about.
Okay, fine. So it's there, along with a little bit around what might you do if the baby's breathing. Bear in mind that not every baby is apneic, so we've got a little bit about provision of CPAP at 6 centimeters for babies who might be providing their own drive, just to remind people that you don't actually have to do mask ventilation for every single baby that comes out, because we're talking about stabilization and resuscitation. Are we talking about the controversial aspects now? Yeah, okay. So ERC there on the right hand side, we have stayed with our recommendations for what we will call longer breaths. They are not sustained inflations, they are longer breaths, and there are 5 of them, and they are between 2 to 3 seconds. So these are not sustained inflations, they are longer breaths, based around some interpretation of, or our interpretation of physiology, which suggests that we need help to move the fluid out of the fluid-filled lung in the first phase before the compliance improves, and then you can move to more physiological ventilation. So it's 5 breaths at 2 to 3 seconds to clear the fluids, after which we ventilate at 30 breaths over a minute, which is the standard recommendation across the board. And we don't give a range, we just say 30 breaths per minute thereabouts, and people make their own judgment of what they're doing, but that's the ballpark to aim for. So it's 5 longer breaths to clear the fluid. Those are repeated if you assess the airway as not having responded adequately, so that's where your airway corrective steps come in. And once you've got the chest moving and you've aerated or the heart rate's come up, it's PPV at 30 breaths per minute, and it's the same as it was because we haven't had any evidence to change it one way or the other.
And I just want to add, we had a lengthy discussions about inflations and so the longer breaths of up to 3 seconds of eye time. And the evidence. There's actually, to our opinion, of our writing group, at that point in time, there was no evidence for superiority nor inferiority of either approach. So your approach and our approach, if I may say it like that. And so initially so in the evidence part, we fully acknowledged that there's no evidence to prefer one above the other. And initially we also suggested, so we left it, we provided both options. And then in the public comment round, we got a lot of feedback. Please give us an advice. Don't leave it up to us. Just give us the one advice. So that's why we stayed with up to 3 seconds, because that's implemented in education and courses and throughout Europe. So that's the reason we stayed with this approach. And we fully acknowledge that actually at this point in time, we don't know what is better. Yeah.
Before I pass to Henry, I want to highlight there is a typo in the ventilation. TI is 0.5 to 1 second.
What? Yeah, one more typo is that for the PIP difference is it's similar. It's less than 32 weeks or greater than 32 weeks the cutoff. So it's more similar actually. We don't actually yeah we it's more similar than we want and we don't actually specify a PEEP in the guidelines, but in NRP we do say 5 is typically the PEEP to start at. We say sometimes 5 to 6. We did change our guideline to the rate of ventilation from it was used to be 40 to 60, and I think based on some of the observational data, we have changed that to 30 to 60. So again, becoming more similar, if anything.
For oxygen.
Okay, I could just start with, so I think perhaps many of you are already familiar. ILCOR reviewed and also based on the large individual patient data meta-analysis that had been done, altered our thinking about oxygen and some of the studies that showed for preterm infants, the goal saturation by 5 minutes being reached, not being associated with some adverse outcomes. So this is one place where we do have a different cutoff where for less than 32 weeks, we have said 30 to 100% as the initial concentration, and 32 to 35 weeks. I think there's a lack of evidence perhaps in this group, but kind of staying then at the same place we were before, 21 to 30%.
Yeah. Again, it's pragmatic, and interestingly here we've changed ours from something very similar to yours to something we felt was pragmatically more similar for the people applying it. So what you've written this time is virtually identical to what we had in 2021, and this time we decided that the bit in the middle was confusing for people, so we took it out. So yeah. So under 32 weeks, it's more than or 30%, and we've left that at the discretion of the institution to decide what they do, recognizing that the evidence isn't clear enough to be totally didactic on the amount of oxygen, other than oxygen may be helpful. And in the more mature babies, it's air. And if that's not working, then you're going to move it up, and it's that simple. And it means there's less for people to think about. And we acknowledge that you could discuss a range, but we haven't. And with saturations, we moved from single values to ranges, because we like to change things. So we had single values last time based on the sort of Dawson data and other data, and now we've moved to ranges because we feel, I guess, that's probably easier for people to aim for. So we've moved the ranges, and we moved the times. I noticed that you've got 5 values on your saturation point, 2, 3, 5, and what have you. We had a 2-minute one before, and we had a bit of a discussion about this. Decided that the likelihood that you've actually got a readable saturation that you could manage in a practical way at 2 minutes was low. And 3 minutes was more pragmatic. So we've just got a 3-minute, a 5-minute, and a 10-minute value based on the curves.
The one with 30% oxygen or more, that was difficult because of the pragmatic approach that we had. So this still hurts a bit, but this was what the evidence said, and we couldn't decide on what to advise if we would aim for a single initial oxygen concentration. But for example, my country, the Netherlands, will provide a specific advice because they didn't want us to leave it open to the individual healthcare professional. And I assume that more national resuscitation councils will try to provide an advice, but this was very difficult because the evidence is not helping us here to provide with a specific initial oxygen concentration. So actually everything between 30 and 100% would be appropriate according to the evidence summaries and updates.
And I think the key word here, and it's not on the slide, starting. This is a dynamic situation which changes.
Initially starting. So, moving towards to advanced resuscitation, chest compression and drugs, we recommend to intubate before starting chest compression and not doing this during chest compression. We know that may be differences of the use of the laryngeal mask. We recommend to prefer intubation if you have the skills, and otherwise you may prefer an alternative, of course. We choose the current dose recommended by ILCOR on epinephrine, and we have this IV flash of 3 mLs based on animal studies. And glucose is not in our algorithms, but it's not that we need to check and insist on checking glucose, but it's not part of the resuscitation guidance. What is new this year on chest compression, we always start with adults, pediatrics, and now the neonatal team are always there after that. So it's the first time we recommend rotating the operator who is providing chest compression to rotate every 2 to 5 minutes. We need to recognize that neonatologists, we are champions, but we also feel some fatigue. So replace your chest compression provider, because it's important to provide effective chest compression.
Oh, that's a very good point. Like the flush, we didn't incorporate it. Probably will look into that for the next version. I don't think these are very minor differences if you look at it. Because of course we also say please consider and anticipate on the need for insertion of a supraglottic airway or tracheal tube when chest compressions are indicated. It's just not that specific that you need to intubate before you go to chest compressions for a lot of reasons. One of the most important ones is that we are not completely convinced that it's always necessary. And the second one is that intubation is a very complex skill, and not every pediatrician attending birth is able to intubate the baby. So they need to have local agreements with anesthesiologist or whomever is going to do that, and to not delay progress of the resuscitation, I guess. And the rest is detail. So for example, the repeat every 4 minutes is just because it's one number. It's in alignment with the pediatric and adult resuscitation cycles of of the rhythm blocks, and it's easier to remember. It's just in between the 3 and 5 minutes. That's just a pragmatic choice. And the glucose is, we got a lot of questions, and a bolus of glucose was frequently administered during resuscitation, and so we looked into that, and there's actually no evidence that you should do so. If you want to do something about glucose, check the blood glucose and only administer glucose if the blood glucose is low. So we're not saying you should measure blood glucose during resuscitation, but if you want to administer glucose, only if the blood glucose is low. So measure it. That's the message that we wanted to convey.
We do at the end of our guidelines document highlight some research gaps, and these are just a few of them that we talk about. There has been really a lot of great advances in clinical research and cord management, and really appreciate our colleagues who are doing that work. But I think there's still more to be done, perhaps in certain populations, including perhaps like multiple gestation or other aspects or risk factors. We also are not we're not sure about the use of a supraglottic airway or laryngeal mask during chest compressions. And then this we talked about it already. Some of the differences that one of the differences that we do have, it's that initial inflation versus just for us just providing ventilation at a consistent or at least a initial inflation time and peak inflation pressure. And then I think we're still learning about the optimal use of interfaces, including supraglottic airway in what circumstance. And then the oxygen concentration, 30 to 100% is a very wide range. And so I think also we're not sure about even subgroups within the different gestational age groups.
Yeah, I see the circulation part fell off, but I guess based on the discussion we had this morning, we may not even know for sure if we should put in a peripheral IV or an umbilical line or an IO. Maybe we also need some more information about the effectiveness of adrenaline, but yeah, those are things for the future. And I would like to state again that I think we have so much more similarities than differences, and the differences are probably the most controversial topics where evidence is not yet enough to support a firm recommendation. So that's definitely work for the future, and I'm very curious about how the evidence will be in 2030. I'm not sure about you. Would it be a good moment to ask if there are questions about the topics that we discussed since the previous questions and answers, and then summarize or wrap it up?
I have a comment and a question. I think the comment is about these little differences between the two. You stated very clearly in your guidelines, you say practice guidelines. So this allows you probably some more room to interpret, to guide the practitioner who needs to actually do something. Yes, 20 to 25, but what should I do? 20 or 25 to have all the team doing the same thing. So that's my comment. My question is about the prolonged inflation of 3 seconds, because you recommended TPs, but I suppose many places don't have TPs, as they have self-inflating bags, and people want to comply. So it's just a question about how you have dealt with it. People that do not have TPs have self-inflating bags, and yet they need to provide 3 seconds of an inflation.
So in the United Kingdom, and within the guidelines and within the NLS course, we acknowledge the difficulty in providing the longer breaths with a small volume bag. So we don't promote the use of the 240 ml bag, and we advocate the use with training of a larger volume 500 ml bag. And with a 500 ml bag, you can provide controlled longer inflations. But clearly, this is the juxtaposition of equipment, training, ability to do it safely. So we use 500 ml bags in the newborn unit when we're not using TPICs. Does that answer the question?
Sounds surprised.
I would add, I'm not aware of an increased incidence of pneumothorax and other problems in babies at birth because of the use of 500 ml bags.
Can you put the two algorithms together? Just a very quick question for both of you. Yeah. So I noticed that in the American algorithm, there is an assessment for if it's term gestation, baby is having good tone, breathing or crying, which we have inherited for many, many years. And then if the answer is yes, then now you do skin to skin with the mother and provide ongoing assessment, which is great. I noticed, so the question for the European is, there is no mention about the skin to skin care at all in your algorithm. Now, the other question for the American algorithm is, it specifies term gestation for this. And that will preclude the late preterm who are doing fine to have skin-to-skin care. It will just hint to the team that if the baby is not full term, then it doesn't fulfill one of the criteria to be with the mom, then the answer is no. then the baby needs to come to the resuscitator. This is what I understand.
The skin to skin is not mentioned in the algorithm, but it's mentioned in the recommendations, recommendation part, and of course supported by the evidence summary in the evidence part of our guideline. And so it's definitely there, but it's not in the algorithm, because the algorithm actually applies to the babies that need our help and will not stay with their mom for the time being. A lot of those things you can do while she's on mom's belly, but that's a different topic altogether. So, yeah.
I want to highlight our intention to be practical, and it has been a long debate about, do we need one algorithm or more than one? So to answer your question about term, we decided to have one algorithm instead of more than one. So some specific details about preterm or late preterm and differentiate that is very complicated in one single algorithm. We can expand on the NRP and in the guidelines more in detail, but to have one algorithm, this is what we decided. I don't know.
Perhaps it's worth just mentioning that we've considered at task force level, and I'm sure all of you have, that we don't exactly know how these flow diagrams are used. For some people, they may be a training aid and a model to develop a shared approach and a reminder, something that we can use in training and in briefing before a resuscitation. But as task force chair, I've also had quite a number of emails from people around different parts of the world that suggest that they read the algorithm line by line as they go. And I think the former approach favors simplicity of presentation, and the latter approach may favor the more detail that Walid is suggesting. I think we might need more evidence about how we're actually people are actually using these algorithms and to whom they're most used. I don't know if any of you have got any comments about that.
Yeah, and the other thing that I was reflecting on looking at the differences is, if I'm red-green colorblind, what does your algorithm look like?
As the red-green colorblind member of the steering committee or editor of the textbook and member of the writing group, the NRP algorithm is red-green colorblind friendly. In fact, it's friendly to any ability to distinguish color. American Heart Association has certain guidelines for the development and publication of guidelines of algorithms. And so this is one very small area where you'll find a distinction between the American Heart Association guideline and what appears in the educational program, the NRP textbook, and the educational materials that support the textbook. So the American Heart Guideline has colors. Those reflect very standard colors on all American Heart Association guidelines, but the NRP text does not rely on color at all.
But on top of this, we have shapes, and the shapes are different.
And what are you recommending that people put on a poster on the wall?
At least in the United States, if you purchase a wall poster, it would be an NRP educational product, and so it would not rely on colors. And the shape of the shapes may be slightly different on the NRP than on the American Heart Guideline, but it's very, very similar.
May I do a comment? I think that there are two, changes that can put together the guidelines. First of all, I like a lot the chain of neonatal care instead of chain of neonatal resuscitation or survival. And so, congratulations, I like it very much. It's very similar to the title that we use in Europe, because we use resuscitation and support to the birth. And so, and the second part is a question: is why did you decide to move from 40 to 60 breaths to 30 to 60 breaths? It's just because you want to be close to the European cuisine again? I don't know. This part are are going the same direction, in my opinion. So this is my question.
Thank you, Daniele. Maybe subconsciously we did want to be more similar, but we did a we did our review. I mean, I know that ILCOR has been reviewing it and hasn't published something about this yet, but looking at some studies that are in the context of thinking about optimal ways to ventilate babies, there's observational data showing that what we consider to be, and perhaps we don't know, but what we think is the optimal tidal volume for newborns there was some evidence to show that going a little bit lower in a ventilation rate may provide the best or somewhat higher tidal volume. So that's why we lowered that to 30 to 60. I will say also, when we were thinking about the time when we provide chest compressions, and we say that there should be a ratio of 3 to 1 chest compressions and the number of chest compressions and breaths, we were already recommending during those times that the ventilation rate is 30. So it's a little bit, if we think back to what it was before, is inconsistent when we said ventilation rate should be 40 to 60, but not when you're doing chest compressions wouldn't really make sense either. So those are some of the considerations.
Just to clarify that the European guidance were shared with us only last week. So
I'm just going to ask a question for the rest of the world of John and Mariah. What exactly are jaw thrusts in a newborn, and how do you do them?
Well, Helen, there are 3 workshops during the ERC conference in which you can practice. So please come play with us. I'll let John answer.
So, yeah, you could read the manual, I guess. The principle that is applied here is based on a presumption that in the hypotonic unconscious infant lying on his back, the tongue will fall back into the pharynx, and the tongue is connected to the jaw. So by taking the jaw and lifting it, you bring the tongue forwards and open up the hypopharynx, reducing the likelihood of obstruction. Now, this is all integrated into the positioning. So this is all part of the initial maneuvers that you would undertake in order to optimize the airway in the baby.
So I'll then ask our AHA-AAP colleagues, do you think this is something where we need another PICO question for ILCOR?
Probably we are waiting for this, and as we discussed earlier offline, we are looking for new large randomized controlled trials comparing the 2 strategies.
Hi. There actually has been a study, at least suggesting that the 2-person technique, in which you probably, so it's indirect, are more effective in lifting the jaw towards the ceiling, is more effective than the 1-person technique. So some indirect evidence at this moment.
So yeah, my question is, I think European guideline recommending assessment of the ventilation every 5 breaths. No? Oh, from the beginning.
So if you have if your 5 inflation breaths have been effective, suggested by an increase in heart rate, and chest movement preferably, but at least and usually, hopefully, an increase in heart rate first, then you continue with consecutive positive pressure ventilation, like 30 per minute, with a rate of 30 times per minute. So it's about getting the fluid out of the lungs and aerating them after birth. And once you have established that, you can continue with your positive pressure ventilation. At least that's the train of thought of the European guideline.
But you can increase pressure as well after the first 5. It says
if you have an indication to do so, yes, it can be one of. So if your 5 inflations are not effective, then one of the airway opening techniques needs to be used, whether it's repositioning or inserting a supraglottic airway, or intubating the baby, or suction on a direct vision, sorry, because you assume there's an obstructed airway with blood or mucus or meconium. one of the airway techniques should be used, you repeat the 5 inflations and reassess the effect. So as long as you're not convinced that your 5 inflations have been effective, you need to change your airway opening technique. And once you are convinced, you continue with like normal ventilations.
That's interesting. That's five, and so that's okay. But the 5 breathing sounds like 2. So usually I wait for 10 seconds, right? And usually, is it enough? Is it enough?
It's 20 seconds at least.
It's 15 to 20 seconds of PPP.
Yeah.
Done properly.
I think for the sake of that everyone can hear it, because we're still online, I guess. So 5 times 3 seconds inflation, 1 second exhalation is 5 times 4 is at least 20 seconds of positive pressure ventilation before you reassess. Huh?
Yes. So,
if I can do a comment, another comment, it is interesting to note that in 2020, in the algorithm, American algorithm, the laryngeal mask appeared only 1 time, while it was reported 2 times in European algorithm. While now we shift. Now in American guideline, you have 2 times the laryngeal mask. Why? I don't know if it is Edgardo or Gary influence there. Why we were not able to include the laryngeal mask 2 times in a European algorithm. No, just to do another comment according to the evidence.
It is good. It's not mentioned. It's included in where is it here? It's included in try other airway opening techniques, which includes the insertion of a supraglottic airway. And in the recommendation part and in the evidence part, there's emphasis on the potential benefits of using an SGA. So don't worry, it is definitely there.
Henry.
thanks. I had a couple of questions. One we were just discussing with Graham next to me is how you assess your heart rate so quickly. So you auscultate. So you rely on auscultation because you do not have an ECG that quickly. So
auscultation is a standard. ECG, use of other means, neobeat, dry electrode technology, whatever, are acknowledged. The ILCOR recommendations for ECG, where resources permit, as an early method of measuring heart rate, forms part of the practical guidelines. So when you actually read it, it suggests that you can use ECG. Culturally, I would suggest in some countries, and I would put the UK in this brand, the use of ECG as a routine method of monitoring is not yet fully established, but I think the dial is beginning to shift. And I think there is an acknowledgement of the value of ECG, providing you recognize that it's just giving you a heart rate. It's not giving you any information about output. It's an electrical signal on whether your heart is beating, and the two things are different. And part of the training and part of what we need to educate people in is where these things fit and how they fit and how you use them to best advantage. And I think that there's a symbiosis between using all of these, but understanding how to use them properly. And that's our job, to train people.
And my second question was, you just talked about jaw thrust, that this is something in an unconscious patient to help lift the tongue. Now your OPA, your oropharyngeal airway, which is actually designed to lift the tongue in an unconscious patient, is generally more recommended as an adjunct if you struggle with ventilation, which one larger RCT has showed could cause more obstruction and doesn't work if the patient isn't unconscious because he spits it out. So even the newborn baby spits it out. So wouldn't be saying only in unconscious patients, as the adults would recommend, or pediatrics, more helpful for the general?
The same applies for tracheal tube, right?
What do you mean for tracheal tube?
I mean, you wouldn't put a tracheal tube in a conscious baby without sedation, I hope.
So in 2021, we had a very long discussion about the place of the oropharyngeal airway, because prior to that, the OPA had been promoted as the adjunct of choice in achieving an airway in situations where you hadn't achieved it by other means, or you needed to secure it to free hands or whatever. The discussion at that point shifted the philosophy to what we called the laryngeal mask and what we now call the supraglottic airway device, although OPAs are supraglottic airway devices, they're just shorter. Because the LM is superior to the OPA in terms of achieving a definitive airway and freeing up a pair of hands. So we took the OPA and deprioritized it in Europe. It's still there for certain situations and certain sort of types of funny airway and what have you. It's not removed, and when you read but the laryngeal mask takes precedence because it's better. Does that make sense? So we prefer to train people now in LM, and we don't train them in OPA, because why use the inferior device? And there is that one paper which raises the question or the concern that actually in the smaller baby, maybe OPAs could actually make your airway worse. So don't go sticking bits of plastic in where they're not wanted.
Unfortunately, that's the same population that a supraglottic airway device is not suitable for due to the size. So for every airway opening technique, you have the same advice. Check if you were effective or not. Every airway opening technique can be unsuccessful or lead to an obstruction theoretically. So I think that applies to all airway opening techniques. I'm conscious of the time, and we'll give the microphone to Henry in a sec, because we have 6 minutes left, and I think Helen wants to wrap it up, or Henry wants to wrap it up. But given,
should I wrap it up? Oh, okay. Well, let me just make a couple comments. I think going back to some of the other comments and questions, ultimately, like the algorithm is, I think we both of our groups tries to make it practical and perhaps simple as we can, while still including as much as we could. And so even the question about skin to skin, in the guideline document, we don't say, oh, don't do skin to skin on a preterm infant. It is more just we were trying to convey the concept. If the baby's term, crying, good tone, then of course you should not go down this path. And so it does not preclude like a late preterm infant, for example, who's crying and vigorous to not get skin to skin. I think those nuances, it's hard to put in like an algorithm document without having too many words. And so even the jaw thrust question, we have in the guideline, the ventilation corrective steps, we describe a 2-hand hold as one of the potential corrective steps, but we just didn't think that it rose to the sort of perhaps in our minds, critical importance of putting more words into the algorithm. And the NRP does talk about how that could help with jaw thrust, I guess, similarly in those instances where you're doing ventilation corrective steps. So I guess I say all this to encourage all of you to actually read the whole document. It's only ours, HAAP is only 39 pages, and like half of that are just references, including many of the studies that some of people in this room have done. And I learned a lot reading the early copy of the ERC guideline as well. So I think we can all benefit by learning from each other and reading the whole document, not just picking out the small differences in the algorithm, which again are small anyway. Yeah, we probably have to. Okay, do we want to have another question or two?
No, it looks as though there are a few burning questions.
We have only 4 minutes to go, so do you want to?
Thank you. I have one question. AP guideline algorithm does not mention about the chest movement during PPV, but ARC mentioned the chest movement. How AP guideline others or consider the chest movement during PPV? This is my question.
We talk about chest movement as well in the overall document, and certainly in the NRP educational materials. We talk about, but we still emphasize that a rising heart rate is the most sort of the sign that indicates effective ventilation.
I have a quick suggestion maybe. Is there an acknowledgement at the beginning of guidelines from where we can see that there's differences, to just acknowledge that there might be different ones around the world, that they are based on the same evidence, but where the evidence doesn't reach what the trainee needs to do, that's where the differences lay. I think that might be helpful if it's not there, because I don't know.
We do describe that this is, in our case, this is for North America, and this is why the ILCOR is the international, and we try to adapt the ILCOR and the current evidence for North America, and each council do the same. I think we have only one.
Sure, people know that.
Yeah, okay, that.
Okay, just a quick one. Why is in the AHA the temperature not included, and also the need for help, which is non-technical, but it could be interesting. I don't know. Just
we talked about it because we were aware of this difference, and I think it's a really good idea to have something like that. In fact, when I teach sometimes to trainees, I mention, oh, by the way, the ERC, their algorithm has that. So it's important. So think about it. I think I think we've talked about it, and we thought for simplicity, tradition, we kept it the way it was. Yeah.
I'd just like to thank all our speakers, because we have only a minute to go in which to do that, for being willing to sit up there and have questions fired at you from the audience about, and I think I'd bring you back to the point that Henry stated at the beginning, and Mariah, is that the guidelines are far more similar than they are different, that these small differences mostly relate to areas of uncertainty about practice, but where it's still appropriate to develop a shared mental model that people are familiar with in particular locations. Maybe it's comforting to refer back to the Australian, the ILCOR motto, which is that any attempt at resuscitation is better than no attempt.
That's a good thing to wrap it up. Thank you so much.
Thank you.